The title of the paper is to study the outcome and complication in 100 eyes by Phako emulsification of high myopes with cataract. A retrospective study for 100 cases for 3 years. Myopic eyes, as you all know, is an enigma because of its inherent structural variations. So here operating on a cataract in such cases is a challenge. I present here 100 cases retrospective study for 3 years. I'm Dr. Chandrakanth. Material methods, 100 eyes with myopia having a cataract selected in the study. It was a retrospective study for cataract for 3 years. A selection of patients, here you can see the majority of the patients come in the age group of 30 to 50. This is a demographic table. Preoperative status, if you see here, the majority of the patients were in the group of 6/18 and 6/24. Refractive power, if you see, majority of the patients, -6 diopters in 14 eyes, -5 in 12 eyes, -8 in 16, and -9 in 21 eyes. To start with, the preoperative assessment as routine for any routine cataract surgery. That's a preoperative checkup, refractive dynamic and static refraction, IOP measurement by applanation, lacrimal syringing to know the patents of the lacrimal duct. Then you have a detailed slit lamp examination to see the corneal status, endothelium, the cataract, any subluxation, any dislocation, such things and all. Fundus examination wherever possible. B-scan, the fundus is very hazy to see the posterior segment, and optical biometry to see the IOL power calculation. Dilated fundus examination was done, and 17 eyes had lattice with retinal holes, which were barraged before the cataract surgery was done. A minimum of 1 month was kept before it was subjected to cataract surgery. But here, only one patient had 1 month duration after the laser. Almost majority of the patients were waited for almost after 3 months. This is a Phako procedure. I'm showing the video. A bent keratome to do 2 millimeters incision. Before rexis, you are doing a staining with the methylene blue, then a side port entry. A large capsular rexis around 5.5 to 6 millimeters diameter. Hydrodelineation and hydrodissection is in progress. Then Phako emulsification, I did a Phako shop. Use minimal power, all power, vacuum, and aspiration, keep in lower parameters. Once the nucleus is removed, the epinucleus is removed with this IA probe. Then once the cataract is removed, the implantation of the intraocular lens into the capsular bag. Remove the viscoelastic, then self-filling incision. Hydration of the wound to self-fill the incision. Intraoperatively, we had one. I had iridodialysis noticed that was not noticed on the table. After 1 month only, we could notice it. The periphery there was a small iridodialysis, which didn't hamper the IOL position. What is? One I had posterior capsular rent at the periphery when the last bit of nucleus was removed. No vitreous loss was encountered, so the IOL could be placed in the capsular bag. Postoperative, one I had a retinal detachment after 18 months after the surgery. Vitreoretinal surgery was performed. This eye had undergone barrage laser for multiple lattices with holes 3 years before the cataract surgery. One had a mild descended IOL that did not hamper any vision. This is the post-operative visual status. At the end of 3 years, almost 32 eyes had 6/6. 26 eyes had 6/9. 31 eyes 6/12. 9 eyes had 6/18, and 3 eyes had 6/24. This 6/24 patients with the last 6/18, 6/24, almost 11 patients had severe choroidal myopic degenerations in the posterior pole. This is the flow chart there. Later postoperative complication we noticed was 3 eyes had post-capsular opacity. One, it was thick at 12 months, second at 20th month, and third at 30th month. All underwent YAG laser capsulotomy with precautions, with keeping a minimum YAG laser power. One had retinal detachment after 18 months, which underwent RD surgery. To conclude, fake emulsification of cataract in high myopic eyes can be surgically managed by taking precautions like using lower parameters like phaco power, vacuum levels, and aspiration days. These modifications should be kept in mind before doing this procedure to get optimal visual outcomes. These are my references. Thank you. SRK2, I think. Yes. Then with the optical biometry, we had a Barrett calculation. Then based on that, we put intraocular lenses. Yeah.
Because
Final is Barrett.
SRK2T usually won't give. Barrett gives a good.
Barrett was used. All cases we use Barrett. Although we have optical, we do a optical this thing, but then finally we go to the Barrett and then only we implant the lenses.
Intraoperative, any issues you had just for the like iris retropulsion?
That is there. So we will have to take precautions. As I said, the parameters are kept lower, and no much more problems. So except the only one patient when they had a small nuclear bit which ruptured the posterior capsule of the periphery. But luckily for us, we noticed it early so that we couldn't. There was no vitreous loss, and we could keep the intraocular lens in the back. That the particular patient had no problems at all. Post-operatively, there's a good visual record, no issues at all. Jay? Not exactly. Not exactly, because I got a little, state-of-the-art Phako machine. I don't want to name the machine. So in that, yes. And again, there's a myopic mode in that. The myopic mode is there. So we do that.